My name is Shanthosh. I'm a cardiologist by training and also doing a PhD with Sam on septic cardiomyopathy. My understanding is that you guys are just, well, some of you, I think Drew, I've seen you before, but most of the other guys, I think, have just started the DDU program. Is that correct? So generally, my understanding is you guys are reasonably fresh in echo. Okay. If I'm too basic, let me know. If it's too advanced, please also let me know. We're going to talk to you about, I guess, kind of following on from Sam's talk last week where he talked about LV assessment. We're going to talk about LV complications. Sorry, we're going to talk about myocardial complications and just some of the applications of how to assess LV regional wall motion abnormalities and how to include that in as part of your LV assessments as well. Let's talk about a couple of cases, and I would like one of you guys to at least put your hand up and tell me what you think of the next couple of slides and what your thought processes are. So I've got a 75-year-old, I was going to say 76, 75-year-old male with hypertension, dyslipidemia, and prostate cancer, which I believe was treated. Presented to a peripheral hospital with essentially 2 to 3 week history of left-sided chest pain. He suddenly got worse. He presented to the peripheral hospital and he was diagnosed with an inferior STEMI. He was transferred to a tertiary hospital, had PCI to the left anterior descending artery and right coronary artery. He also had a first diagonal, which was disease, which was also treated. But a couple of days later, he had worsening multi-organ failure on day 3 with increasing shortness of breath, orthopnea, tachycardia. He had intermittent AF, had acute kidney injury, LFT derangements, and he was really struggling to survive. He was subsequently intubated after he failed NIV, and this was his echo with us. Let me put this to full screen. Sorry, what was that? Anyone want to have a crack at this?
Can't see this playing though. Is it playing or?
Give me a second. I'll fix that. Stop sharing, share. Window. How's that?
Better.
You can see it moving now?
Yep.
Great. All right. Anyone want to have a crack at this?
I can try and have a go.
That's yeah, absolutely.
Or one of your DDU candidates. Sorry, I'm not a DDU as yet, so let's not rob anybody of opportunity. Sorry.
Cool. Anyone want to have a go? Otherwise, I'm happy for you to have a crack. There's a couple of other cases, so don't worry.
Sure. Okay. I mean, first of all, it's a bit surprising that the contractility looks good in the context of the MI. So I suspect they are on some vasopressors and inotropes at the moment as we speak. Just focusing on the LV at the moment, the septum seems to be contracting, but bouncing at the same time, especially the basal septum, which is probably in keeping with the MI, but overall visual impression of the contractility is that it is contracting well, the whole left ventricle. Then looking at the mitral valve, in the 2-chamber view, the mitral valve seems to be doing a decent job, but in the 4-chamber view, I feel like the lateral cusp may not be moving as well, but
hard to say, but yeah.
Yeah, hard to say. There's no color there. So maybe that is something I would be interested going forward. And in heart, what view would that be? Image number 4. It's subcostal, I think. Yeah.
Yeah,
So
that's a subcostal view.
in the subcostal view, I think it's off axis because otherwise it looks like a kissing left ventricle, which I don't believe I saw in the other films. But yeah, I think there is in the third image, the left ventricle seems like almost kissing as well over there.
Yeah.
Predominantly, one of the things that I can see is that decent contractility, which is not in keeping with somebody recovering from an acute MI, maybe anatrobes vasopressors, maybe bleeding from the angio site, and they are underfilled as a differential. I would like to see the IVC as well, and to see if they are well filled or not. Now, coming to the last image, I'm actually worried about the right heart. Don't know the tap.
Yeah.
Doesn't look like the TAPC is great, and the longitudinal contractility seems to be compromised. So my money is on the right heart failure or underfilled LV because of some bleeding issue / inadequate
Yeah, absolutely.
resuscitation.
And I think I agree with you. So just to summarize, there's a couple of points that you've highlighted. So what we were talking about is, if you see, can you see my laser pointer there? So where my laser pointer is, you can see both of the LV walls, both the septal walls and the lateral walls, are really almost coming together, and it's kind of more obvious in the subcostal view, where it just almost what was mentioned was it was kissing. And that's a good sign. I mean, that's a sign that, the LV is likely underfilled, or we're really hammering this guy with catecholamines. And the question is whether we need to back off from that and also fluid resuscitate this. You can also see this when you've got kissing ventricle, when there's hypovolemia secondary to other causes such as bleeding. So it's an important aspect. So when you see this, you're like, oh, LV looks probably underfilled. Or we're really smashing this patient with catecholamines, and so we need to fluid resuscitate this and see what's going on. Most of the LV cavity segment or LV walls look to be contracting well, particularly in the 4-chamber, 2-chamber, and also the 3-chamber view there. And the subcostal view looks reasonably okay there as well.
A small disclaimer before you
Yes.
go to the money. I think I got waylaid by the fact that they angioed the LAD as well, but I now recollect the first sentence was it's just an inferior STEMI. So
That's
probably
right.
it's all the RCA which was the culprit. Okay, sorry.
That's exactly it. No, that's a good point. It's always important just to have the clinical context in mind. But you're correct. The right, I do agree with you. It looks like it's it's not as contracting as well. And what we're talking about is it's really not really coming in. So basically in the 4-chamber, you can see that the RV, it's not contracting, or the walls are not coming in towards the septum. And even the longitudinal function, I mean, if I put my pointer there, it's not really going up and down. A good RV really should go up and down. That's what you measure using TAPC or RVS prime. That measures your longitudinal function of the RV. So this will be in keeping with the clinical context. Let's move on. Does this help you moving on to the short axis? Does this help you?
So am I seeing a mechanical complication of the MI is my worry, because the you know how these LV cavity, circular LV cavity should be circular, but there's a big gap on the top left. Whether am I? Yeah. I'm not sure whether it's just a quirk of imaging or there is, because if you see that in the third image, there is probably the same thing propping up again. So hard to say. I'm struggling over there. Whether if we put color there and if we can see if there is a mechanical complication leading to a VSD. There you go.
Does this help?
Yeah. It confirms the diagnosis.
Absolutely. Does that make sense, guys? There's if I go back, or even in this image, you can see that there's almost a gap, and really you should see a circular. Remember the first slide, it was all circular. So there was a gap in that. And sometimes it can be off-putting because you're not sure whether you've just scanned it off axis and you've got something wrong. So it's always important to double check, or most importantly, put color through that. So color shows that you've got some flow or significant amount of flow going from the left to the right ventricle. Does this help you as well?
Sorry, not so good. Yeah, don't do these Dopplers.
This, if you just go for basic principle, this Doppler is just showing you that it is flowing in that direction. So from the left to the right. I don't expect you to know what the pressures are or what this is, but it shows that, you know, the Vmax in this case is 4 meters per second. It is a reasonable amount or pressure across that ventricle, across that VSD. So this patient does have a VSD, and it's quite significant. You can see with the color Doppler there.
It's a red in color, so towards the probe. Is that correct? Right. So if it is towards the probe, it's going towards the right atrium, right ventricle. Sorry.
That's correct, because the right atrium is just there.
Yeah.
Remember, blue away, red towards, or Bart Simpson, if that helps you to remember. So you obviously have to have another look and have a closer look. They've gone back to the subcostal view. Looks like there is a VSD there. And they've put color across there, and that confirms it. So it's always important to see whether you can get the same sign or findings in different views. And obviously, sometimes you may have to go off axis to really grab the money shots, essentially. So don't always stick to your routine, but it's important to go fishing for it, essentially. That is the
ECMO cannulation.
Cannula.
So did we miss it in the 4-chamber view? Or
the 4-chamber, you couldn't see it.
Okay.
You couldn't see it. So that's why it's important. You always, try and have a look at all of the other images and views. And then really, it was the short axis that really gave it away. And then the off axis images. What am I trying to show you guys in this, with this slide? It's the same patient. And I've just highlighted the fact that the LVOT VTI is 14 compared to the RVOT VTI, which is 22.
Basically just showing that he's nearly got twice as much output going through his RVOT as his LVOT. So that you could probably, I don't know, figure out a shunt fraction off that if you were clever, I suppose.
Yeah, exactly. You can do QPQS shunting, but just basically, not even just a step back, your LVOT VTI in a normal patient or normal circumstances, your LVOT VTI is always higher than your RVOT VTI. If your RVOT VTI is higher than your LVOT VTI, then you should be looking for a shunt, assuming that you've done the measurements correctly. Does that make sense? So it's an important and a simple trick. Just to look at your LVOT VTI, yep, it's 19 or whatever, and your RVOT VTI, yeah, it's 14 or whatever. Your LVOT VTI is greater than your RVOT VTI. It's a good, just a sound check. I mean, a visual check to say, hey, I've got no shunts or whatever. If it's the other way around, like in this case where your RVOT VTI is higher than your LVOT VTI, it suggests that there is a shunt. Does everyone understand that? The VTI, what it does, it's essentially a column of blood through that segment. It's a velocity time integral. And the way I understand it, if I've got, I don't know, a can of Coke that is going in, I should have a can of Coke coming out, essentially, because it's a fixed chamber. Otherwise, if you're losing something, if you get a can of Coke going in and a half a can of Coke coming out, then either you've done the measurements correctly or it's going somewhere else, or the other way around, which is when you're looking at the shunt, where you've got more coming in and less coming out, like in this case, then you definitely be looking at something else, and shunt is the first thing that you should be asking yourself. Does that make sense so far? So I'm just highlighting this because it's a common question or thing just to look out for. And I know Sam loves to ask this question, so it's something that's to be mindful of. So the neat trick. While I'm on this slide, does anyone want to comment on what is a good LVOT measurement? how do you like check yourself or check someone else's work that they've done the correct assessment of an LVOT VTI?
I can have a stab.
Yep.
So like when you're looking at the still or the 2D still, you should check that the Doppler alignment and the LVOT alignment, hopefully with some color flow, are all as close to 0 as possible. If any more than sort of 10 to 20 degrees off axis, then you'll be underestimating. And then looking at the trace itself on the pulse wave trace. So these ones probably are maybe not ideal. My understanding is that they should have a really clear envelope and then be sort of hollow. Well, yeah, the RVOT ones are much better than the LVOT ones. That's probably a better way to describe it. Yeah.
Yeah.
A clear envelope that then you can trace around the outer limit of, or the more inferior limit of, on that graph, I suppose.
So remember, yeah, absolutely. So compared to your LVOT VTIs, which kind of look pretty hazy and not as clear cut as the RVOT VTI, what you're talking about, or what you really want, you want the modal velocity, the most amount of red blood cells going through that chamber. And you really want this a good envelope where you've got really a thicker line and a hollow line inside, whereas when you're looking at the LVOT VTI, it looks all hazy. You don't really know what you're measuring. So that's one way to say, hey, I need to get a better kind of trace. So you may need to realign your probe or your sample volume to try and get a better envelope. And then when you're on the LVOT VTI, how do you know whether you're too close to the aortic valve or whether you're too far? Because remember, it's a sample volume that you're taking, and depending on where you're sampling will determine what your LVOT VTI is.
You should just have a closing click. If you get both opening and closing, maybe you're too close, and if you have none, you're too far. Would that
Absolutely.
be fair to say?
That's exactly right. So you should get a closing click, kind of like this there. You shouldn't have any, there's a bit of opening click on this one there, but you shouldn't get an opening click. If you just need a closing click, so that way you're in the Goldilocks zone. If you've got no clicks, no closing or opening click, you're somewhere in the ventricle. And if you've got both opening and closing, you're too close to the aortic valve. So just a closing click, a good envelope. You want to make sure that it's at least 2/3 of that segment, that your reject velocity is nice and small. And that way it's a good just self-assessment to say, okay, this is a good LVOT trace, or this is not a good trace and I should probably do a better one, or have another look at it. Does that make sense?
May I ask a couple of questions on LVOT VTI?
Yeah, absolutely.
One would be, what phase of respiration, does it matter if they're intubated versus they are spontaneously breathing? Because when they're spontaneously breathing, we tend to do it in end expiration. Is that what we follow when they're positively pressured ventilated as well?
I don't really think it makes it. We don't really wait in clinical practice. We don't really wait for them to just change parameters. There is subtle variations of it. Changes to it. So what you can do, if you see a significant difference, you take an average of at least 5 measurements to try just to equal it up. But otherwise, most of the time, the sonographers will not be waiting around for in the respiration phase.
The other one was, if you don't get a good alignment, or if you're not in the right Goldilocks zone and you are essentially far away in the ventricle, are you underestimating the output or overestimating? I was thinking maybe underestimating.
You'd be underestimating because the gradients won't be as high unless they've got HCM or something, but you'll be underestimating it. So so that's why it's important to try and get the Goldilocks zone. Hope that makes sense. Let's move on. Next case. So any questions about the VSD complications? The issue with this guy was that he had a delayed presentation with an inferior MI. They've subsequently gone and stented pretty much into the dead myocardium, which was not of any benefit for him. And as a result, that He's had necrosis and all of that, and ended up with a VSD. We don't see this as common nowadays. It used to be quite a big thing, particularly in the thrombolysis era, but nowadays with immediate PCI and the on-call teams, you rarely see this now unless they really present late. So that's why that has occurred in that case. Next case, 65-year-old man with from Southeast Asian heritage, sent in by GP with chest pain. He had an onset of central heavy chest pain at 11, went to the GP, who did an ECG and called the ambulance straight away. Pain was associated with diaphoresis and dyspnea. He had chest pain for 2 weeks prior. And ECG showed sinus rhythm with ST elevation in V1 to V5 with deep Q waves. Anyone want to have a crack? This is the parasternal long axis and a short axis view. Anyone sitting enrolled in the DDU that hasn't commented? What about Lucas? Do you want to have a crack?
Yeah, I was having a go last time, and I'm only doing EDEC. I'm not doing DDU either, but I can have a go.
That's all right. Anyone else? I'll have someone else have a crack if they're not responding. I'm happy for you to have a go crack. Yeah, you can have a crack.
Yeah, sure thing. So I think the money's probably in the anterior and anterior septal regions. Look like they're poorly contracting. Looking at the parasternal long, RV looks like it's working well. The infraseptal wall looks like it's contracting, and the parasternal short in the base there, you can, I think it's the septal area largely and the anterior areas.
Yeah, absolutely. For the guys who are sitting Lucas, I agree with you. For the guys that are sitting for the DDU exams, I would systematically start off and say, look, this is a parasternal long axis view of this patient. Looking at the overall LV function, it seems to be contracting well, although I would like to have a look at this in different views. Looking at the RV function, it looks like it's contracting reasonably well. The aortic valve appears to be opening and closing well. The mitral valve appears to be opening and closing well. The LA maybe seems mildly dilated, although I'll have a better quantitative assessment on subsequent chambers. That's how I would do it in DDU exams, or when you're doing your vivas or your presentations and your teachings. And then, say, looking at the short axis view, the anterior septal walls are hypokinetic. The remaining walls appear to be contracting well. The mitral valves appears to be opening and closing well. And that's how I would just I want you to get into the motion or practicing and just presenting it like that. Okay, moving on. Anything with the color? For Lucas?
Sorry. We're again parasternal short axis at basal view at the basal segments there. The there's a little flash of regurgitation through that mitral valve that I saw for 1 second, not even that, and I don't know if I got too much else to add that looks abnormal.
So I'm not wanting you. There's nothing too much to add on this, so that I would comment on. So, and this is just to the apex. Moving on to the next one.
So we've got an apical 4-chamber view, and then one that's zoomed in more on the right ventricle on that apical 4-chamber. So probably in keeping with what we were seeing previously, the segments that appear to be poorly functioning. So the apex certainly appears akinetic, and Yeah. In the apex of the left ventricle as well, there's, I don't know if that just spontaneous echo contrast due to the poor contraction there. It doesn't, I don't think, look like a thrombus, but it's weird, and I'd want to interrogate that a bit further. And then just looking more broadly, the visual assessment of the right ventricle looks okay. Both the tricuspid and mitral valves on this 2D view look like they're coapting normally. Again, maybe the left atrium slightly larger than the right atrium, but it's not super dramatic. And I'm just looking at that zoomed in right ventricle. I don't think I've got anything else to add.
Yeah, no, 100% agree. The LV apex is akinetic, and the anterior septal wall and the anterior lateral wall is hypokinetic, particularly compared to the basal segments. And can everyone see the SEC, or also known as spontaneous echo contrast? Does anyone know what that is? What does that reflect?
Just stasis
Is
in
it
that
the
area.
rupture of the papillary muscle or something?
Not papillary muscles. It is stasis of blood. So this is like, red blood cells and platelets kind of really clumped up together. Sometimes you can get this, when your gain is super high, and that's one of the ways to make sure that if you see this, you turn down the gain and just reassess it to see actually is this actually spontaneous echo contrast, or SEC. SEC means there's low flow there, or slow flow, just there's blood pooling down. And moving on. Anything there, Lucas? You can still see the SEC. Anything else that you would think? And the two.
So looking at that 2 chamber, so that's going to be showing me more of the anterior wall. So anterior and inferior walls, and I would say the inferior wall is looking good, and the anterior wall is probably at least hypokinetic, and again akinetic in the apex. And I'll look at the 3 chamber you've got. So look, the spontaneous echo contrast is visible in all 3.
Okay.
Yep. Valves again looking like they're doing what they should be doing. Yeah.
And what are they doing here?
So we've back to an apical 4. We've zoomed right in to that apex and looking for areas. We're zoomed in presumably to try and look to see whether there's any actual clot. So,
do you think there's a clot there, or not sure?
So myself, not sure. What I'm leaning towards no, because I can, at least on one grab on that color view, I'm getting there's a flash of red going right to the apex. Maybe on, I don't know. I think that warrants probably a contrast study. There might
Absolutely.
be on the septal wall, maybe a little area that's not ever lighting up in that zoomed up view.
Absolutely. And I think the key thing that you said was that you need contrast, right? I'm not sure what I have. And then they're just doing a bit more color there. What about now? Do you think there's a thrombus there now?
So look, there's, I would say, yeah, it looks like there's a little fimbriae of something. Maybe that's just the swirl of how it's flowing.
What about
Can't say
now?
I've looked at too many contrast studies. That looks like there's definitely something floating around in the middle there. Yeah.
So can you guys see that there where my laser pointer is, or that red marker there? That's your clot there. Remember when you guys looked at SEC and that slow flow? This, you can see it much more easier in terms of how slow the flow is there. So let me see whether going back, see if I can going there. This is all thrombus. Now, what they're doing with color flow there is it's like a poor man's contrast. And nowadays, this really, I mean, you could just do it for, I guess, funsies, but anything more, you definitely should be looking at contrast or having contrast if you're suspecting that there's a thrombus there. You can kind of see there, and just in the apex, it doesn't really go all the way, and you can't see the trabeculations there. And the clue also was that you've had spontaneous echo contrast in the patient who presented late with an anterior infarct. And the other clue was he had Q wave, so you know that this is a delayed presentation. He's had an established infarct. So putting it all together, you've had, look, okay, this guy really hammered his anterior wall, and the apex is akinetic, which is really a sitting duck for a thrombus. This is just thrombus, contrast to swirling around, and in a normal contrast echo, which I'm sure Sam will have a session on, you'll see a good round of pacification of the LV endocardial borders. So, and here it's kind of just sticking out there like a blob, and that's your thrombus there. Put in the context just for side things, I don't expect you to know this in your DDU exams at all, but this is just where the LAD is coming down. This is your diagonal, and this is your after stenting shots there that, you know, the LAD is nice and open. So anyways, just for some fun in terms of the clinical context. Does that make sense so far? Happy with that? So we've seen those two complications. Hopefully we can, couple more minutes, we'll go race through the last one. 50-year-old male presented with 10 out of 10 chest pain just an hour and a half ago, radiating down the left arm. He had hypercholesterolemia, prediabetes, smoker, and the cath lab was activated for a STEMI. Someone else want to have a crack at this? I actually can't remember what this.
I can go if there's no one else.
Yeah, absolutely. Go for it.
All right, cool. So we've got a peristernal long axis, upper left corner, short axis in the top right corner, apical 4-chamber and inferior lateral chamber, and then a 2-chamber inferior right. In the left, you could see the left ventricular function appears mildly reduced in that particular view. The aortic valve is opening up normally. The mitral valve is opening up. Excursion is normal. And perhaps some inferior lateral regional wall motion abnormalities. I just have to look at different views. Moving to the short axis view in the top right. It just froze.
Is it frozen for all of you?
Right, it's back now, I think. Or maybe it's my computer.
Oh, mine's running a bit slow and stop start as well.
Okay. Yeah.
Sorry, guys.
That's all right. We'll power through it. Gosh, so it looks like the inferior septal, inferior and inferior lateral at the kind of mid area is hypokinetic. Within the limits of this. Within the inferior lateral region, I think that there's some hypokinetic regions in the mid-inferior septal and probably the apical septal region.
Yeah.
And in the 2-chamber, I think clearly there's hypokinesis in the apical inferior. Froze again, but I think it was more hypokinesis in the mid and the basal inferior regions as well.
Yeah, I think so. I agree.
The walls, I say, would. Yeah, go ahead.
Yeah, go for it.
So what area, what territory is that? Probably more of a kind of, could be multi-coronary territory given ID and maybe circumflex. And it appears more acute given there's no thinning, there's no evidence of aneurysmal changes. And the presentation sounds pretty cute as well.
Yeah, so I think those points are very clear. And we haven't talked about the thinning and the dilatation of the cavities, and those are very important points. And usually, sometimes if if there's thinning, is another sign of that this is more of a chronic process, and this doesn't appear to be the case. And I agree that this is most likely the inferior segments that are hyperkinetic, and it's also obvious in the short axis where it's not really contracting as well. It can be the circumflex. I guess it depends on the dominance, but predominantly this region is supplied by the right coronary artery. And again, you can see that, basal septal walls not as contracting as well as you'd like. And remember, right at the beginning when I went through the regions and the territories of the slide of which coronary artery is supplied, this is helpful because if someone comes in and, for whatever reason, ED's not sure what territory infarct it is or whatnot, you put a quick probe on, you kind of have a better idea what you're dealing with. And just for fun, this is the right coronary artery on the top left, which is completely occluded, which is what was the culprit. But you were quite correct because he had disease elsewhere, including the LAD and a bit of the circumflex. So you did see some other regional wall motion abnormalities. So you quite correctly said this could be a multi-territorial involvement. But the acute case, or the acute was the right coronary artery, which was ballooned up, which is not fixed there yet, but was eventually, there we go, eventually fixed and stented. So,
Sure.
But yeah.
From the acknowledging the anatomical variability with the coronary territories and that, would you put a lot more emphasis on the right ventricle and its function? If you see inferior regional wall motion abnormalities, and if the RV is reduced, like maybe second glance, the RV is impaired actually in that inferior view, that maybe you're more inclined to say the RCA. Whereas if it's preserved, then you're leaning more towards circumflex.
Absolutely. I mean, I would look at it and say, look, in here it's a bit difficult to say because there's a bit of dropout, so it's not as clear.
Yeah.
But I would definitely have another focused view of that, or see. I mean, in the parasternal long, I mean, it looks really. It's hard to say. There's a bit of like wobble there if you can kind of convince yourself there. So it's not completely normal. But I would. What you said is quite correct. I would go back and say, hang on, is there something? Did I miss something, or is there something like to try and help you which territory it is? But inferior is generally the RVs involved. And these guys, if they're super sick, they need a lot of filling, right? So, but that's how echo really can help you out in terms of trying to figure out, okay, what is the RV looking like? Is it dilated? What is the filling pressure? Is there significant TR, etc.? All of that stuff will be helpful. I think we're generally out of time, but I just, out of curiosity, what was this case? 41-year-old. Presenting with central chest heaviness following gardening, ST elevation. Anything there that jumps out for you guys quickly? In terms of the walls? Do you think that the inferior segment?
Inferior and septal look hypokinetic.
I think so. It's a bit harder to say in terms of the anterior wall, but it looks like there it's okay in the four chamber. There it looks like it's contracting reasonably well. He had an inferior STEMI, PCI distal RCA, and then had a cardiac arrest. Oh, I remember this. Okay, so had a cardiac arrest, balloon pump was inserted, went to ICU. He had increasing inotropic requirement after, which was a red flag, because you've essentially fixed the culprit, which was the right coronary artery, and you assume that you've done all the right things. You may, I mean, this may be a bit too advanced, but this is looking at a toe. This is the aortic valve. This is the mitral valve. Any quick comments about the mitral valve? Just at the color itself. Torrential flow, right? There's so much going through. Anything there that pops out? So this is a toe, which is kind of upside down. This is your left ventricle, your right ventricle, your mitral valve. I don't expect you guys to know this just yet, but later on. Can you see something?
Anterior flail leaflet, is it?
Absolutely. Can you see that? There's a bit of, I don't know, something just going into the left ruptured chordae or something that's going into the left atrium. There you go. What's that? What's this?
Muscle.
It's his pap muscle.
Yeah, pap muscle ruptured, right? MR, severe MR. So this guy had a ruptured pap muscle. And you can see that a bit more obviously there. Obviously, this is this guy needed urgent intervention and went for surgery. But if, like, I think I was trying to highlight there, like, okay, with yeah, there it is. What I was trying to highlight there was that, and this is a valve after it's fixed. Anyways, it's contracting. What I was trying to highlight there in that case is a patient, yes, he had an inferior infarct, he was fixed, went to your department or ICU or wherever. He was really failing to thrive because he was becoming more and more hypotensive and shock. He had VF arrest, so there's some signs of ischemia still going on, and the nurses are cranking the NORAD up and up and up, and there's you really have to ask yourself, is there's something not right? And echo is really helpful in terms of not only as a diagnostic tool but also monitoring tool, because particularly in critical care, the patients are so dynamic. You really have to go back and have another assessment and have another look, whether it's with an echo or a probe, which most cases will be doing that. But in this case, this toe was done in the middle of the night after putting the probe on the echo and saying you can see that severe MR. It's like, look, this is not right. This is probably a flail segment or ruptured pap muscle, which is, again, rare or not as common, but it can happen. But that's just a side point. So I hope that makes sense in terms of the, some of the complications of MIs and how to try and assess for regional wall motion abnormalities and some of the complications that can be associated with MI. If you have any questions, please fire ahead. But thanks for your participation.
I'm sorry, can you hear me?
Yeah, absolutely.
Oh, sorry. Yeah, my camera isn't working. I was just wondering with the VSD and with the QPQS thing, there's because it's an intracardiac shunt, right? So there's still. I was just wondering if with an intracardiac shunt there should be less flow going through the pulmonary valve, because some of the flow has gone to the LV, right, from the LV.
So
there's more flow in the from the pulmonary valve VTI than the LVOT VTI. But would that still make sense if it's an intracardiac shunt?
Yes, it will still make sense. So you will still have a slightly higher RVOT VTI in those circumstances. So it's important, like if the RVOT VTI, assuming that all of the measurements are correct, if it's elevated, then you definitely have to be looking for a shunt. So it will still make sense in that case.
Okay.
Anything else? Cool. Anyways, thanks, guys. Wish you all the best in your DDU journeys.
Thanks so much, Shanthosh.
No worries.
Have a
See
great
you
one.
guys.